almost 90+% of the patients who progress through first line will make it to second line. And second line options will depend on what you've done in the first line. Like I said, for most US physicians, chemotherapy plus bevacizumab is their primary option. For some, on the left side, RAS wild type, BRAF wild type, HER2 non-amplified, they choose to start with an EGFR inhibitor plus chemotherapy. So let's first start with all these patients who will receive chemotherapy plus bevacizumab in the first line, regardless of their genetic or molecular subtyping. Second line, you switch the chemo. So if you start with FOLFIRI, you go to FOLFOX. If you start with FOLFOX, you switch to FOLFIRI. And then you have the option of continuation of the VEGF inhibitor. So bevacizumab, you continue bevacizumab to the second line. I think on the right side, that makes sense. On the left side, however, that only makes sense in those patients who have RAS mutations or HER2 amplifications. For the BRAF mutations, that's a particular case. For those patients who have RAS wild type, BRAF wild type, and are HER2 non-amplified, if you started with chemotherapy plus bevacizumab, your second line has to be an EGFR inhibitor plus chemo. And the reason for that is because we know that EGFR inhibitors work pretty well in this group of patients, and I wouldn't want to wait to third line before I initiate that treatment. So for those patients, you can use EGFR in the first line, then possibly VEGF inhibitors, so bevacizumab in the second line plus chemo. If you started with bevacizumab, then an EGFR inhibitor in the second line. For the BRAF V600E, we try to have them either on a clinical trial with a RAF plus MEK inhibitor plus minus EGFR inhibitor, or now the NCCN guidelines do list this as an option, which we sometimes consider utilizing. On the right side, it's Bev, regardless of the mutational status, and then the third line would be regorafenib, or TAS-102 would be an acceptable option. On the left side, again, regorafenib would be your third line option, or TAS-102 again would be an acceptable option. So what percent of patients actually make it to the third line is we think up to 50 to 60% of patients who started first line will end up in third line. When you get to fourth line, you lose even more of those patients. It'll end up being about 25 to 30% of the patients that end up in fourth line. So if you use regorafenib, which I do in my clinic, in the third line, then TAS-102 follows. If you use TAS-102 in the third line, then regorafenib would follow. For the case of the HER2 amplified patients, second line, usually we shift them to one of our clinical trials with a drug called tucatinib plus trastuzumab. That's a study that we have in our site and a number of other sites nationally. And that essentially bypasses the need for an EGFR inhibitor, which we know from other from the MD Anderson experience, at least in 2 cohorts, that those HER2 amplified patients do not seem to have benefit from EGFR inhibitors. That kind of makes sense, understanding the interplay between EGFR and HER2. So it's not surprising to see that if there's a benefit, it's minimal. Now, a very important question is, as we move beyond second line to third line, is what do you do with those patients in the third, fourth, or fifth line on the right side? Do we ever expose them to EGFR inhibitors? The answer is, although the data is very weak for EGFR inhibitors, even though those that are RAS wild type, I still think there's a place for them. There's a study that looked at essentially EGFR inhibitor cetuximab versus best supportive care that suggested that in the later lines of therapy, there may still be a little bit of a survival advantage for cetuximab versus best supportive care. There was no PFS advantage, but overall survival advantage. And that could essentially tell us that there may still be a role for EGFR inhibitors in later lines of therapy in patients on the right side. I usually use it after regorafenib and possibly after TAS-102 if I run out of options. On the left side, in the HER2 amplified patients, the RAS wild type HER2 amplified patients, I get back to these EGFR inhibitors sometimes around between the third and the fifth line of therapy. There are nuances, of course, to all these. The MSI high patients go on a PD-1 inhibitor and try actually to move it to first line if the insurance will allows me, but I wouldn't wait beyond the second line. That's for 4% of the patients. So it's a landscape that keeps on shifting, but overall, parts of it remained quite stable.